Hello, I'm here with Dr. Rozzano Locsin in the Christine E. Lynn College of Nursing Center for Caring, and we're here today to discuss technological competency as caring in nursing. Good afternoon, sir.
Good afternoon, Terry. How are you?
I'm just wonderful. Delighted to finally have you in that chair.
Yeah, well, yeah. I always say, who can say no to Ann Boykin? So, so that's where we are at this point. So thank you.
Well, great. So our first question, I want to start out with talking about your theory on technological competency as caring in nursing. It is indeed very relevant in today's nursing practice. So could you talk to me and our audience about where the idea originated from and who influenced your theory development?
Thank you. The idea came about based on the fact of technological competency grounded in competency, which is part of the ingredients of caring, actually attributes of caring by Sister Simone Roach. She has these 6 C's. So being competent. But then the idea came about as to why do we need to have technological competency? Why do we teach technological skills? Why do we make sure that students are skillful and be competent in the use of technologies? So I thought the idea was, it's not simply the competency, right, that is important. Competency can be on anything, but in today's age, technologies are important, and so having technological competency as caring is important, especially at FAU College of Nursing, where our philosophy is grounded in caring. So how can being technologically competent expressed as caring? So what is it? Many times people think that it is technology and caring as a combination, and then you have technological competency and that's going to be caring. That's not the point. The point is your technological competency is caring. So that's the thing that we should always understand. It's not technology plus caring equals so and so. So it's your expression of caring, that it is your technological competency that is the expression of caring, that is nursing. Okay.
So essentially you actually evolved past Sister Simone Roach's comments. You know, one of my favorite quotes is her discussion of caring without competency being brutal and inhumane. But indeed, you're taking that a step further in your work.
That's actually a good statement that I always kind of use. Competency without compassion is brutal, and compassion without competency is irresponsible. So that in itself argues the point that we have to be technologically competent, and this technological competency is being caring. So it moves into the direction of how is caring expressed in our nursing. If nursing is caring, therefore being technologically competent is caring. So that's the argument kind of thing.
Terrific. Can you talk to us a little bit about the substantive parts of your theory? You know, what are the concepts?
Okay, there are basically, if you look at the major concepts, it's technologies, caring, competency, and nursing. But I have this theory has five assumptions, and I always look at assumptions as the pillars of the whole theory. So you have persons are caring by virtue of their humanness, right? And that's, I think, the most important thing to consider. Persons are caring by virtue of their humanness. And so that is actually derived from Boykin and Schoenhofer's nursing as caring. And the idea of all persons are caring is critical, because a person can be made up of parts. A person can have an artificial leg, an artificial arm, can have bioengineered pancreas or whatever you call it. But these persons, they are all human beings, and they express their caring in ways that are important to them. So many times being human is being caring. So that's important. And I know I can go to the whole idea of is if all individuals are caring persons, then how about the rapists and the murderers and all this other stuff? Well, they are caring persons if we agree to that, well, we subscribe to that assumption, but their expression of caring is different. That's the argument that we have to remember. The expression of caring is different.
Indeed, and,
Right.
and that's,
So that's
how students struggle with that
exactly
assumption.
Right. They're all caring persons. Yeah? They care for something that matters most to them, if you have to use Boykin and Schoenhofer's thinking. But their expression is different. It's not our way of caring. It's not the other person's way of caring, but it is their expression of caring. So, but that doesn't mean they're not human. Okay. And that means that they're not caring, but they're caring for whatever it is that they want to care for. And the next one would be that technologies are used as the ultimate expressions of knowing persons as whole in the moment. So persons as persons, that's what Dr. Schoenhofer and I were discussing last week, if you have to put the time. We were talking about persons as whole in the moment. And so she and I, we were discussing. It's often a question that's asked by people. So persons are whole in the moment. What does that really mean, right? Well, the momentary wholeness expresses the way in which a person becomes the focus of your nursing. So your technological competency allows you to understand and know this person more fully in the moment. That moment will change. Why? Because the person is not predictable. Human beings are unpredictable, irreducible. Therefore, right, you only know the person in the moment. And that is most important. How can you express yourself in the moment? You can say what matters most to you. Again, getting Boykin and Schoenhofer's important statement. What matters most to you at this moment? That allows you to understand this particular person.
So
Yes.
are you saying that technological competency as caring in nursing requires an intention to be in the moment?
Sure. All right. I always believe that nursing is grounded in intention. It's your intention to care, right? And that has a whole meaning, and we can go into the whole discussion of intentionality and intention to care, and whose intention is it, and what is the intention of the person who is being nursed, all right? Do they want to get well? How are we to understand how they want to get well, or what is health to them? What is the intention? So intentionality and intention is critical to our understanding of person's health. Now, I use health as a generic, can be expressed as well-being, and things like that. So,
Well, thank you. Can you describe a little bit about the evolution of the research that's been done in terms of technological competency as caring in nursing, and what are some of the practice aspects of the theory development itself?
right. Let me start with the research. There are, I look at the phenomena where we look at the nursing phenomena that is involved in the idea of the theory itself, technological competency as caring in nursing. What are these phenomena? I focus on two phenomena looking at persons being cared for with technologies, and phenomena about caring for persons with technologies. It's both the nurse and the patient. So I thought that's a good that's a good
wonderful
basis.
structure,
Right.
great basis.
Caring for persons who have technologies and persons who are being cared for with technology. What is it like to have a bioengineered pancreas, for example, or an artificial leg, or a pacemaker, or AICD, or all those technologies that make a person live longer? Or
Which keep
live.
evolving more and more.
Right, and that's actually a good way, especially at these times where we have all these persons coming home from different wars, different battles, and then they lose parts, and then we replace them. And I always ask the question, what for? And again, the idea is, well, because they will miss. But how do we know they're missing the part? We replace these parts with technologies. And how is it like for them to live with artificial parts? All right? That is a phenomenon where you have persons being cared for with technology. They are being cared for. They're living their lives more fully as persons with this particular technology. So anyway.
So essentially the possibilities of studying technological competency as caring and nursing are endless because technology keeps evolving and growing.
Right. And I remember Patricia Monhall, the first few years I was here, I had this poster, Self as Technology, and she actually said, oh, God forbid. And I said, human beings are technology. If you look at the meaning of technology, technology is, you have a Heideggerian definition of technology. It's anything that makes things efficient. Right? If you look at the wheel, all right, just imagine how if there was no wheel, it would have been a very big problem to live in this world. But we have the wheel. Now imagine the wheel to be a square, not round, right? How efficient is that? There is no efficiency in a square wheel. It will exert more energy. So anything that makes things efficient is technology. So if a human being can make things efficient, a human being, therefore, is technology. And we will go back to that idea when we talk about robotics. As the theory evolves, which is actually fascinating to me, right? At this point of the evolution of the theory. So
I'm really personally interested very much in the practice aspects of your theory and the potential impacts on care. So talk to me a little bit about that.
So when it comes to practice, I always, the idea is that, so how will a nurse practice nursing using the theory? So I have identified a process of nursing I call knowing persons as caring. So originally, I have to have a way to provide an understanding of how it is that today I have there are three dimensions. I call it dynamic process events. It used to be, as the theory was presented or published initially, I looked at the process of nursing grounded in or based on Kristin Swanson's theory, being with, doing for, etc. Right? But as I grew in my understanding of technological competency as caring and nursing, eventually the idea focused on three dimensions or the three dynamic processes, which are technological knowing, mutual designing, and participative engaging. So if you look at technological knowing, I mean, it makes sense. It's using technologies to know persons more fully in the moment. Okay, so using technologies, however, whatever technologies that allow you to know the person more fully. For example, if you use a sphygmomanometer, so you determine the blood pressure. That is the person's way of letting you know who he or she is in the moment. That's the momentary expression. That's a momentary way by which you can know who this person is. If your intention is to know every part of this person, that person will not appreciate who you are as a nurse. But what is important to you in the moment is know me as a person. You know me as a person with high blood pressure. So deal with that, because that is most important to me at this moment in time. So that allows you to know the person, that particular technology. It can be EKG, it can be anything that allows you to know the person more fully in the moment. So that's technological knowing. Then you have mutual designing. Mutual designing is, so you have the patient or the person, if you like to put it that way. And so how am I supposed to care for this person given my technological competency, right? So it should be a relationship between the nurse and the person being nursed. So entering into the world of the other, using my technologies, right? The person will tell me, I mean, not literally, will tell me who he or she is from the perspective of the measurements that I get from various technologies, because technologies are simply representation of that which is true. Technologies allow you to know,
what is real and what is true by representing that which is real and what is true. Again, we can use the sphygmomanometer. The blood pressure of 120/80 is not your blood pressure. They're simply representations derived from your sphygmomanometer that says your blood pressure is 120/80. It is not the blood pressure. So that's the argument. So all these technologies give you ideas or give you the understanding that this is who the person is.
So they're components of knowing. They don't essentially replace personal knowing or all the ways of knowing.
You can use Carper's ways of knowing, if you like to look at it that way. Mostly empirics, aesthetics, ethics, and personal. But the idea of mutual designing is the person and the nurse and the person and the nurse and the person being nursed actually design their own, design the person's way of being cared for. Okay.
So setting goals mutually, etc.
Yes, that's a good way to put it. So the responsibility is not given to the nurse alone, because the nurse is allowed to enter into the world of the person. And the person actually allows the nurse to enter into the world. If he or she doesn't allow the nurse, or doesn't allow the nurse to enter into his or her world, he or she can say anything and whatever, and there's nothing you can do about it.
So there's free will and adherence, etc., around,
yes.
For instance, that example of blood pressure management.
Correct. So you have to. There has to be a relationship, and that relationship is illustrated in the mutual design. And then you have your participative engaging. All right. Now the participative engaging is how the nursing unfolds. The nursing practice unfolds based on what you know is through technological knowing, and what your plan or your process of nursing has been using mutual designing. And now you're engaging. Now the engagement is a recursive, ongoing process, because there is no way that you are going to say, oh, I already know the patient. That's not possible, all right? Because the person is unpredictable and irreducible. So that person will grow in his own time and in his own way, given using statements from Meyerhoff's Ingredients of Caring.
So essentially, an example that I can think of for that would be that technological competency as caring in nursing is evolving when a nurse goes and responds to an IV pump alarm. If she's demonstrating technological competency as caring in nursing, it's more than just resetting the alarm.
Right. And the idea of you going to the person's bedside because the alarm is going, it's to remind you that this person is actually telling you, come and see me through the technology. So this is part of technological knowing as well. So perhaps somebody can write on this idea of coming to know person using technologies. That's
wonderful.
Really very interesting to know. I thought everything has been written about technological competency, but so many things like space of togetherness, technological encounter. There's so many things that really needs to be understood. So
we've talked a little bit about people and theories that have influenced your theory development. Have we captured all of them? You mentioned Boykin and Schoenhofer. You spoke briefly about Roach's work.
Right.
Are there others that you think have?
Kristen Swanson is another one. Gene Watson's idea of human caring as well. Important among all would be Marilyn Ray's theory of, she has bureaucratic caring, but before anything else, she had technological caring. And that I got, she published a research she did a phenomenological study, and she came up with 27 statements that actually expresses technological caring. And actually, initially you mentioned about research, so I said, I think I forgot about the research, but the development of the instrument, a technological caring instrument, was the first instrument that was developed grounded in Ray's theory. the technological caring theory. Okay, I call it a theory, but she may not have addressed it as such. But that was the impetus for the whole technological caring instrument, and from there was developed technological competency as caring in nursing instrument. So that's the evolution of the instrument.
So talk to us a little bit more about that instrument and how you would measure technological competency as caring in nursing.
Good point. It's the idea of like Parcells and I had a research study. It was published part of the John Weimer distinguished professorship grant that I got, and so we studied the idea of how do nurses express their technological competency. And again, the statements are based on Ray's original research and the technological caring instrument. The purpose was to determine what is technological competency as caring as known by the nurses themselves. And the next study was supposed to be looking at how do patients understand what is technological competency as caring in nursing. That has not transpired yet. Okay, so that's one of the things that I am looking at. How will patients or persons being cared for understand that technological competency is an expression of caring in nursing, and does it matter after all? Okay, so that's the future kind of thinking that I have. Another set of studies was I mentioned about the phenomena of being cared for, the phenomenon of being cared for, and the other phenomenon of caring for. There are probably about 3, 4, or 5 studies being done about these particular phenomena. And
that's fascinating to me. Can you speak a little bit about that? I know a lot of folks internationally are using your work and expanding your work.
Yeah, one of the researchers who have been nurse scholars or researchers who has done studies on caring for and being cared for is Waraporn Kongsuan, who is a graduate of Florida Atlantic University actually, and is now is actually a faculty member of Prince of Songkhla University in Thailand, and she has done lots of studies. When I say lots, about 3 or 4 studies on the phenomenon, both phenomena of being cared for and caring for. Rebecca Kosolinsky, an FAU PhD graduate, also studied the idea of being cared for. And other students are looking at the instrument, looking at the validity and reliability of instruments given Spanish translation, Japanese translation. Actually, now it's being done in Japan. There's a translation of the instrument. And then one that was studied in the Philippines was, of course, in Filipino, which is the language. One that was done in Spanish was by a master's student in Columbia University in Bogota. So, and these are all published. So, if anyone would be interested to look at that and learn from it, it's one of the. It's been good. So, ultimately, talking about research. The question is, so what? So you have all these instruments. They're valid. They're reliable. So what? Okay. So the important thing is the idea of what is the value of having a technologically competent nurse who expresses caring? What is the value of a nurse who has this kind of practice? Well, I figured the way to determine whether or not this person is valuable, or this characteristic, if I like to put it that way, or this practice is valuable, is to look at what are the outcomes if the person expresses technological competence as caring in nursing. So I thought one of the areas of QSAN, I think, is patient safety.
Absolutely.
So you have patient safety. You have patients' falls, medication errors, pressure sore formation. If you do a retroactive studies, you can say, were they technologically competent nurses? If you have technologically competent nurses, would the incidence of falls and decubitus ulcers and medication errors decrease? I mean, you can argue perhaps that may be true and that may not be true, and so you would like to look at whether the value of having technologically competent nurses, right, and the practice of knowing persons as caring. So that has not been done yet. So I think it's something that really needs to be looked at.
And even, there have been many technological advances to support error reduction in healthcare, and often what I see in practice is there's an intention to not use the technology that's been developed fully for that purpose. So
I wonder why.
That's another intriguing thought in terms of often more time-consuming, and not fully understanding the potential impact on error reduction. And I know we have other students here at Florida Atlantic in the Christine Eland College of Nursing who are currently just beginning their doctoral studies that are using technological competency as caring in nursing as foundational to their work. I have a student, Shiana Reed, who is currently looking at the vital signs devices that can look at trends and predict the potential impact of having a rapid response or leading to a code blue, and the call for nursing that is put out in response to that change in the trend in the vital signs.
And that brings us actually to the idea of the universal technological domain, which is one of the more recent I don't call it iteration, but more recent idea or evolution of the theory. Where is this? What is it? Okay. Well, the universal technological domain is supposed to be the end-all, be-all. Okay. That's where all technologies that influences our understanding of the theory and how technologies influence human caring occur. I mean, that it's not a setting, but when I say occur, it's where you can probably see representations, right? And the way to illustrate it, to look at the endless infinity kind of thinking, is the use of Mobius, the mathematical structure where there is a beginning. Ideally there's a beginning, but there is really no end. And the idea is because knowing persons as caring never ends, right? You know the person continuously from moment to moment to moment. And so there is no end. And so the universal technological domain is where all these things occur. It's very difficult for me to say where all technologies happen to be used, because technologies are everything that makes things efficient. What is it that doesn't make things efficient? Right? Then you will make a qualification, oh, that is not technology, this is technology, but that's not possible. Because everything that makes things efficient is technology.
So since we're talking about robotics, can you talk about your most recent book and describe that for us?
Okay. Well, the book is entitled Nursing Robots, Robotics, Technology, and Human Caring for the Elderly, actually. And it is I would like to say a compendium. It's an anthology of works, original works, actually. There's probably 1 or 2 or 3 reprints, but the idea is addressing nursing robots. All right. I don't like to use the word. Well, we understand that nursing can be a noun, a verb, and an adjective. So here it's an adjective of robots, and so the idea is how are we going to use these robots, and what are robots, and things like that. And it's a good understanding that we should have is what is it that we mean when we say robots and nursing? We have anthropomorphic machines, we have automatons, we have artificial intelligent machines. All these things are robots. People in the industrial world would say, when you say robots, they're all about mechanical devices that they use to lift whatever it is, to draw things and things. But in healthcare, we also use industrial robots. That's not what we're talking about. We're talking about healthcare robots that facilitate human caring. So given that idea, we look at humanoid nurse robots. Humanoid because they are patterned after human likeness. We can say there's many difficulties with developing humanoid robots that will look more human.
Certainly.
And, there are not conflicting, but there are two thoughts. You have Masahiro Mori's Uncanny Valley, which looks at the idea that we should not, it is a problem, not we should not, but it is a problem when we develop robots that really look like human beings, because then people will look at this robot and say, oh, it's really a robot. But that's not the point. We're not asking them to look at robots and think that they're human beings. That's not the point. We're losing the focus of what these robots are for. And there's another school of thought where we look at robots that should have parts that are much like human beings, so that they can be more appreciated. For example, currently we have Pepper. Pepper is a robot that's about 3 feet tall. I think it's 120 centimeters. And it is programmed. Two basic programs is to look at children, to entertain children. And the other one is for elderly persons, all right, to keep them company. They can do stuff, all right? They can interact. There are some limitation to the interaction, but they're able to do things. And in between, you will have other robots. Artificial superintelligence is what we're talking about, and that's all addressed in this book. And the computerization, the age of computerization from analog to digital, now to quantum computers. And I am actually reading a book now, and it's about the emotion aspect of computers. When I say computers, we're talking about computers that are not based on zeros and ones. They're now exponential, and that's why they're called quantum computers. And it's out there, fascinating, because that's the only way by which our artificial superintelligence can really meet up at a point where there is an actual conversation between or an interactive conversation between human beings and humanoid robots. So these are things that are addressed in this book.
And you focus on the elderly population in this
Correct.
book. How did you come to that understanding?
It was because that was where the funding was. I mean,
Certainly.
That's the only way.
Certainly, as researchers,
Right.
we get that.
Yes, and so, but the idea is, if you look at Japan, all right, the elderly population is I think 60%. Don't quote me on that, but there are more elderly population, and then there's the very young.
So population health.
Yes, population is the driving force. All right, so we have to, and then human resources are not able to keep up with the demands of elderly care. So they're valuable to most elderly care demands. Other thing is in Japan, in industrialized countries, I would say, citizens are all familiar with robots, right? And so it's nothing new to them. So they deal with robots just like anything else. And there are many types of robots. So it's just that they are helpful. They keep company, they entertain, they facilitate activities of daily living. There are so many, and this is one thing that probably needs to be addressed. I actually kind of categorized 5 dimensions of technologies, which is part of the whole theory. Actually, you have technologies that mimic human beings. We have technologies that facilitate nurses in their care, like gadgets and instrumentations and computers.
So before you go on, so the ones that mimic, that would be like the simulators that are being developed?
Correct. Right. They mimic human activities. Then you have one that facilitates nursing, like gadgets.
Absolutely.
You have electronic health records and things like those. Those are all computers, and those are all technologies. Then you have nurse bots. These are really, they not only mimic, but they look like human beings, because that's most important, and that's where Pepper and all these other humanoid robots come into place. And then you have technologies that enhance the qualities of persons, meaning you have artificial skin, artificial organs, and things like that. They make your life better, shall we say? And I'm always reminded of Terminator Salvation, if I have to say it, where this guy touched the face of Arnold Schwarzenegger and says, "Oh, you must be, you are artificial, aren't you?" Right, or something like that.
So would those include technologies that are essential for life, like the LVADs and the devices that people who are in severe heart failure or end-stage cardiac disease,
Absolutely.
that is supporting them to have any kind of quality of life?
Exactly. That's the category of mimicking human beings, because they replace some of the activities that human beings require in order to be living, I think. So,
And we'll see more and more of those.
Oh, absolutely. And so you asked the question, I mean, going back to the research, in my initial research about the experience of persons who have pacemakers, one of the themes, the categories expressed by these participants were ceaseless fear. I said, ceaseless fear of the instrument or the gadget to fail. So if your pacemakers or whatever run out of batteries, which doesn't really happen nowadays, but they will die. So there's always that fear of the technology failing them. So that's ceaseless fear kind of thing. So that's one of the things, yes.
So these folks who, the patients and persons who have these LVAD devices, they have to participate in a center which has the competencies necessary to care for them. And in our recent hurricane, I'm sure that they felt ceaseless fear, because they need to be where they can have the batteries charging. And
absolutely.
So absolutely, that makes sense.
And that's probably one of the things that we need to really look at. Understand that these folks actually are fearful. Right? Even if they have successful, they're successfully living with technologies, there's always that requirement, because technologies, until such time as we have technologies that will replicate itself and have wireless charging and all those, they still need energies. And that's the most important thing, is they will run with the energy that is included in this particular technology. So.
Thank you. So we talked a little bit about other theorists who've influenced your work, and you mentioned What Matters Most and Anne Boykin and Savina Shonifer's work and nursing calls and responses. So would you be able to describe a nursing situation that would be an exemplar of technological competency as caring in nursing?
Sure. I'm reminded of I may not be able to tell this story completely, but there was this situation where a nurse, a patient was actually asked the nurse to kindly change my IV because he was not comfortable with it anymore, and the nurse was saying, "I better change it now because all the troubles, all the chaos that will happen between shifts may not allow the incoming nurses to change that until such a later time, and that's going to be a problem." So she did it. Okay, but before she could do it, because she knew it was a hard stick, she got this viewfinder, okay, the instrument, a vein finder actually. So she used that and she got it perfectly. Okay, although nowadays we already have venipuncture robots. Okay, but that's another technology that can be used. So she did it, and it was done, and the patient was so happy, right? Because actually his comment was, seldom do you have, you are probably the first person who was able to insert my IV that didn't have to insert it again and again and again. Okay?
So with that degree of difficulty.
First stick, okay, and he was able to get it. And so it was also reinforcing for the nurse, because then he was able to do it, right? And he was able to make the person live better, because it was in a non-dominant hand. So instead of having the IV on the right hand, because the patient was right hand, he put it on the left hand. So now the patient is able to do things better. Okay. So if you look at the process of nursing, knowing persons as caring, technological knowing, know the technology that allows you to do these things. Mutual designing, it was a design between the person, between the nurse and the person being nursed. And the participative engaging is the appreciation of both the nurse and the person being nursed, having had the opportunity to do this. So I thought that was a good example of a story that makes this process of nursing live meaningfully.
Yeah, that is indeed a beautiful exemplar of a nursing situation, which leads very naturally to my next question. What do you think the implications of your theory are for quality improvement and evidence-based practice?
Yes. One of the things that, to get the common understanding of evidence-based practice or whatever, but it always points to the idea of outcomes. There might be many definitions of outcomes, but let's just say outcomes of care, right? As implied by the being a technologically competent nurse.
Certainly.
So again, I go back to the research study of looking at the value of a technologically competent nurse. But how do you measure the technological competency as caring in nursing nurse, right? So you have to have that TCCNI, I like to call it, the technologically competence as caring in nursing instrument. And the valuing that goes with whether or not it can reduce patients' falls, not when I say it can reduce, whether or not a nurse who is practicing technological competence as caring in nursing reflects reduction in patients' falls, medication errors, and degree of pressure ulcer formation. And I know it's difficult. You cannot do it is a cause and effect relationship, but I think the best way to do it would be retrospective studies. Because then you don't have to identify the nurse who's doing it, but you can deduce that in fact, there's a reduced medication error, reduced patient falls, reduced pressure formation, and you look at these nurses, then you can probably say, okay, administer a questionnaire, your TCCNI, and see if they're really technologically competent. Right. So that's the kind of methodology that I thought may work.
Looking at both different types of technology as well as nursing's competency with that technology.
Exactly, right.
So how should educators use the theory of technological competency as caring in nursing when teaching and learning with students who are studying nursing?
Okay. One of the assumptions that I had in my theory is that persons are whole and complete in the moment. And so this brings me to the idea of simulation technology, right? And I think it's everyone in this world who teaches nursing are now gung-ho about simulation technology and the idea of prediction and prescription. That's exactly what it is. But I think you and Dr. Keller has studied the idea of infusing caring in understanding simulation technology and how it translates into practice. So while we're teaching the technological competency, which is what you get out of simulation technology, one of the things that we have to stress is the idea that you are having your competency, you are getting your competency with technologies as expression of caring in nursing. It's not simply skill acquisition, right? Because then you become a technician, right? There's nothing wrong with the technician, but the idea is that that is what you should be using. And then another research opportunity would be, how is it translated into practice? Now, you can do both ways. You can ask the nurse how it's being how they are able to translate it into practice, or you can also ask the patients, does it matter whether or not this nurse is educated as a using simulation technology or the traditional way of practice? Now, how will they know? Right? They don't have to know. The patients they don't have to know whether or not this nurse is or was educated using 50% of their clinical practice as through simulation. But you can deduce that they have been educated, and then what was the patient's evaluation? That's just a thought. It may not be well thought out, but...
No, the implications of that are fascinating, particularly since it's still not clear, can you help a nursing student engage in relationship with a simulated patient?
Exactly. Right.
And what types of clinical experiences can those experiences replace?
And I think the clinical instructor has to have that, has to be challenged. And must be able to utilize reflective knowing, because it's only in the reflective part of knowing that makes things come into view. While the nurse or the student is doing, the focus is not on the caring, but on the acquisition of technology. And that brings us to, again, Benner's novice to expert thinking. A beginner, right, will always focus on the technology, right? But the clinical instructor has to bring this and make it live. That's a challenge of nursing education, particularly in clinical practice.
As you were speaking, Dr. Locsin, I couldn't help thinking about the differences from a nurse who's prepared and from a technological school and focusing on isolated skills or tasks with technology, and then the benefit of being able to pursue additional scholarship at either a baccalaureate or graduate program, and focusing and working with faculty who are grounded in technological competency as caring in nursing, and looking and evaluating the differences.
Yeah, right now we have no way of really saying that one is better than the other. But the idea is that we are saying that nurses should be caring persons. Right? I mean, that's the idea, that nurses are caring persons. I mean, all persons are caring, as we all know. But if the focus of this technological school is skill acquisition, and they come to us and learn nursing, it behooves us to really make them aware, make them understand that their skillfulness is an expression of caring. It's not simply skillfulness. I mean, that's not the end, but it's actually the beginning of how we come to know persons more fully as persons. And I think the theory can facilitate this using the process of nursing, which is technological knowing, mutual designing, and participative engaging, all occurring in the universal technological domain, which is everywhere, anywhere, and that's where it is.
I think clinical faculty in particular will find that discussion that we just had on this topic fascinating. What do you think, we've danced around this, what is the significance of having a technologically competent and caring nurse? For you, as you think about this work on a daily basis, you're constantly reading and studying on this topic. What is the so what? What is the impact?
We have to be cognizant of the fact that technologies are here to stay. There is no ands, ifs, or buts. It is here, whatever that type of technology is. But Pauls in 2016 says there's no such thing as technology. There are technologies, which are many types of technology. And so the idea is we should make people understand that these technologies are here to stay, and that we have to grow and use these technologies in a way to understand human beings as persons. And that, I think, will make nursing live longer as a profession and a discipline, when we are challenged, we have to be challenged to really grow our understanding of what nursing is. Okay. There is actually an article by Jackie Fawcett et al. It was published in 2015. It was rethinking the name of our discipline, something like that. And they revisited the idea of nursology. Okay.
Nursology.
Yeah, revisited the idea because that was Patterson and Zerad. And I think it is time to really revisit and really think seriously about what it is that we are studying in nursing. And if we are studying nursing, then by all means it is nursology, studying nursing. And if we are practicing nursing, then we are nursologists. That, I don't know, some people say, why do we have to divide the levels of nursing? Why not? There are physical therapists, there are physical therapy technicians, there are pharmacists, there are pharmacy techs. They are different. They have different practices. Why can't we have nurse technicians and nursologists practicing nursing? I mean, that's just, I thought would be fascinating, interesting, challenging, and brings us to a different level. The image of the nurse really needs to be understood, and we have to separate ourselves from the idea of simply doing technical skills. Nursing has gone from the apprenticeship model to a thinking, learning model, and that's probably how we should look at things, especially the challenges of technology. Yeah.
I find that so interesting. I have posted by my computer in my office, what is nursing? Going along with that discussion, that dialogue that you just had.
Yeah.
So you've led me to our final question, although I hate for this time to end.
No problem. Yeah.
What areas in nursing need to be explored more in the future, Dr. Locsin?
That's a difficult question to answer, but I will attempt to answer. The idea is to look at what is nursing? I mean, you just mentioned it. I always think that with technologies out there, with the currency of technologies in healthcare and in nursing, we have to revisit the idea of nursing, the ontology of nursing. What is the nature of nursing? It cannot be nursing of Nightingale's time. It cannot be nursing during the 1960s. By the time 2050 comes around, it will have to be a different nursing. And we have to continuously revisit the idea of what it is, what is the nature of nursing. It will be a different practice. So your epistemology will have to change as well. And the axiology, the value, will have to change as well. It cannot be the same. We have to grow with the times. And if not, we will be, we all know very well, we will go extinct. Okay? And we can be replaced. And if our practice of nursing, going back to robotics, if our practice of nursing is simply task orientation, task completion rather, if it's simply to complete tasks, because that is what technicians will do, my robots will be the perfect nurse, if you have to put it that way, because they will be more precise, more predictive, and they can do a better job, because according to your program. Now, the ultimate question you will ask with technologies out there would be, can humanoid nurse robots replace human nurses? Right? And I leave that to the next generation to really kind of answer, because by the time my answers now may not be appropriate, because we don't know what happened to technologies.
Well, I'm going to hold with the premise that you are not replaceable as nurse, Dr. Locsin.
Well, you know, I remember the movie Transcendence with Johnny Depp and so on. So we can, the computers can actually get what my thoughts are and then store it somewhere, and that is not far-fetched. It will happen. So.
Thank you so much.
Oh, you're most welcome.
For sharing
thank you for this
with
opportunity.
Us.
And thank you to the Anne Boykin Institute and to the College of Nursing for allowing me this opportunity.